Yellow eyes don't mean a liver disease. Jaundice is a biochemical sign, not a diagnosis. Jaundice is the visible yellowing of sclera, skin, and mucous membranes caused by bilirubin accumulating in blood. It becomes clinically visible when serum bilirubin exceeds 2 milligrams per deciliter and bilirubin starts diffusing into body tissues. Jaundice is classified by the site of the problem. Pre-hepatic jaundice is due to hemolysis, with predominantly unconjugated bilirubin. Hepatic jaundice, due to hepatocellular dysfunction, shows predominantly conjugated bilirubin, with ALT and AST higher than ALP. Post-hepatic jaundice is due to obstruction in biliary tract and shows predominantly conjugated bilirubin, with ALP much higher than ALT and AST. Hemolytic jaundice begins with excessive destruction of red blood cells. This occurs in conditions like hemolytic anemia, hemoglobinopathies, malaria, or transfusion reactions. Increased red cell breakdown releases hemoglobin, and the heme component is metabolized. Heme is converted to biliverdin by heme oxygenase, and then to bilirubin by biliverdin reductase. This leads to increased production of unconjugated or indirect bilirubin, which is lipid-soluble and water-insoluble. Unconjugated bilirubin circulates in plasma, tightly bound to albumin, and is transported to the liver. The liver hepatocytes are biochemically normal, and UD-pGlu-curonal transferase activity is intact. This activity converts unconjugated bilirubin to water-soluble conjugated bilirubin. However, the bilirubin load exceeds the liver's conjugation capacity. As a result, there is predominantly unconjugated hyperbilirubinemia. Because unconjugated bilirubin is albumin-bound, it cannot be filtered by the kidney. So bilirubin is absent in urine. Increased bilirubin reaching the intestine leads to increased urobilinogen formation, causing dark stools due to increased stercobilin. Liver enzymes AST, ALT, and ALP remain normal, distinguishing hemolytic jaundice from hepatic and obstructive jaundice. Hepatic jaundice results from intrinsic hepatocellular injury, as seen in conditions such as viral hepatitis, alcoholic liver disease, drug-induced liver injury, cirrhosis, or ischemic damage. Injury to hepatocytes disrupts normal bilirubin handling at multiple levels. Uptake of unconjugated bilirubin from plasma is reduced due to impaired carrier-mediated transport across the hepatocyte membrane. In addition, decreased activity of UD-pGlu-curonal transferase leads to reduced conjugation of unconjugated bilirubin to conjugated bilirubin. Simultaneously, damage to bile canaliculi and transporter proteins impairs canalicular excretion of conjugated bilirubin into bile, causing reflux of conjugated bilirubin back into the bloodstream. As a result, plasma bilirubin levels rise, producing a predominantly conjugated hyperbilirubinemia. Because conjugated bilirubin is water-soluble, it appears in urine, leading to dark urine, while reduced bilirubin delivery to the intestine decreases stercobilin formation, causing pale stools in severe cases. Hepatocellular damage also causes leakage of intracellular enzymes, resulting in a characteristic laboratory pattern in which ALT and AST are markedly elevated compared with ALP, distinguishing hepatic jaundice from obstructive jaundice. To summarize, hepatocellular jaundice is caused by liver cell injury. Impaired uptake, conjugation, and excretion of bilirubin lead to predominantly conjugated hyperbilirubinemia. Conjugated bilirubin appears in urine, and ALT and AST are much higher than ALP. Thanks for listening. Like, share, and follow the channel to keep learning biochemistry the clinical way.